Hi, this is Rosemary Teamy, and we're going to be talking about some gastrointestinal disorders today. We will not be covering liver diseases. Liver diseases will be covered in third semester. The first thing we're going to talk about, come on computer, let's work, is gastroesophageal reflux disease, or GERD. And what GERD is reflux. It's a backward flow of the gastrointestinal contents into the esophagus. And if we think about it, first of all, our gastric juices are very acidic. And our esophagus is not made to endure all of that acidity. What happens is we have an incompetent lower esophageal sphincter. So that sphincter that goes from the esophagus to the stomach. And so that becomes incompetent. And that reflux that's in our stomach goes through that lower esophageal sphincter and irritates up the esophagus. So we get that irritation from the refluxate. The other thing that we will have is some abnormal esophageal clearance, so that the esophagus doesn't go backwards. It doesn't go back down into the stomach. So the inflamed esophagus cannot eliminate the reflux material as quickly or as efficiently as a healthy one. So the duration of exposure to that acidic ick is going to be worse. We're also going to see a delaying in the gastric emptying. So if we have a delay in the gastric emptying, all of that backwash is going to actually backwash up into the lower esophageal sphincter. And then it will backwash up into the esophagus. Now, y'all are wondering what can cause this. Well, we know that there's a lot of things that can cause this. Any decrease of the lower esophageal sphincter pressure can be due to, first of all, foods. Caffeine, chocolate, peppermint. We have the drugs, anticholinergic medications. And if you think about it, what do the anticholinergics do? Cholinergics are the ones that are rest and repose, and so these cause an increase in the anticholinergics cause an increase in the GI motility. Also, the beta blockers can affect it. We know that obesity is the first risk factor, and actually that should be number one, is one of the causes of GERD. And especially those patients that have abdominal obesity, those will have an increase in risk of GERD. Anybody that has an increase in intra-abdominal pressure can exacerbate GERD. Cigarette smoking, cigar smoking. Another common cause of GERD is called a hiatal hernia. What problems we can see with this is that we can see adult onset asthma. So what happens is actually the reflux that's in the gut that goes up into the esophagus, goes up into the mouth, and so we can have some dental deterioration. We can have some adult onset asthma. We can have some aspirations from all of that acidic ick getting into the getting into the trachea and actually causing damage to the trachea and those bronchioles. Patients can also develop laryngitis because, again, that acidic ick from our gut, or that acidic reflux from our gut, can damage. If it gets high enough, it actually can go up and cause brash in the mouth and burn our teeth, burn our larynx, and burn our trachea. One of the big complications of this is called a Barrett's epithelium. And this is that constant reflux up into the esophagus can cause, you can see it on this picture here, hopefully. You can see all of this redness. Well, that's just years and years and years of that reflux from that lower esophageal sphincter incompetence burning the esophagus. This is actually a precursor to esophageal cancer. So patients that have GERD and do have reflux, they need to be assessed for Barrett's epithelium. The other thing is that constant irritation on the esophagus can cause an esophageal sphincter, and that causes esophageal stricture. I apologize for that. I don't know where I'm thinking. But the fibrosis and scarring can actually cause a narrowing in the esophagus. We can have esophageal ulcerations where this ick actually burns through the serosa, through the mucosa, through the serosa, through the muscularis, and now we have this huge big ulcer there. When we have that burning through the muscularis and we can have a hemorrhage. And then another thing, like I said before, with all that ick coming up through the esophagus, we can develop some aspiration pneumonia. Another problem with some GI problems is paraesophageal hiatal hernias. And the paraesophageal is the rolling hiatal hernia. And this is all or part of the stomach pushes through the diaphragm because of an anatomical defect. The herniation, the portion of the stomach can be small or large, and it's actually not a weakness in the muscle. When we have paraesophageal or rolling hiatal hernias, we're not going to see the GERD. We hardly ever see reflux as a result of this. The sliding is believed to develop because of muscle weakening in the esophageal opening. The sliding are the most common, and the hernia moves freely or in and out of the thorax during changes in position, or it can be actually changes in intra-abdominal pressure. With the slidings, we're going to see reflux, and we're going to see that abdominal ick or that gastric ick coming up through the esophagus. So we have the paraesophageal and the sliding. The treatment for the paraesophageal and or the sliding is to do a Nissen fundoplication. And what this is that's a repair of the hiatal hernia. They actually take part of the stomach and bring it around and suture it so that it forms kind of a, if you will, a lock washer on top of the esophagus so that it can't get up into the diaphragm. Some of the problems with an Nissen fundoplication, first of all, is your patient, they have to open you up. So your patient's going to have abdominal surgery, and because we know the esophagus goes through the diaphragm, one of the big problems is our patients, through the surgery, will develop pneumothorax. So your patient coming back from a Nissen fundoplication may actually have chest tubes because they had to go through the diaphragm, which causes a deflation of the lungs. Some other problems that we can see is a peptic ulcer. Oops, sorry, I'm not sure what's happening here. Peptic ulcer disease. This is a lesion in the mucosa. It's a mucosal lesion of the stomach or duodenum. So again, we can see irritation of the gastric mucosa, and we develop a break in the mucosa. And as a result of that, we're going to have the stomach acids and pepsin are going to eat away at that ulceration. We have three different types. We have the gastric ulcer. The gastric ulcer, again, is in the stomach. The duodenal ulcer is in the duodenum. The stress-related ulcers, these are for patients that have physiologic stress. And so most of our patients, and you probably have seen this in your clinicals in the hospital, they're on some type of proton pump inhibitor, be it Nexium or omeprazole or Prilosec, any one of those. And that's to prevent from that physiologic stress. We have an overproduction of gastric acid. If we have a break in that gastric mucosa, we're going to see irritation from that, and we're going to actually develop that gastric ulcer. Some of the common complications of peptic ulcer disease, number one is hemorrhage. This is where we actually, rather than just the mucosa being irritated and inflamed and have that ulceration, we can actually, again, go through the mucosa, through the serosa, to the muscularis. I even had a patient at one time who had a peptic ulcer and actually had a gastric ulcer, and I wound up having to send him down for an esophageal gastroduodenoscopy, and when they did that, he actually had the ulceration over the top of an artery. And so he bled profusely until they were able to band it. For patients that have hemorrhage, it can be either bright red, so if, again, like my gentleman who had the arterial ulceration, it was bright red blood. I knew it was bright red blood, knew it was arterial, and oh my gosh, we got to do it. Hematoemesis is another one, could be coffee ground. So with coffee ground, it's blood that's been digested. And so it's not as severe, but it can be. Some other problems that we can see is perforation. This is where, again, the ulceration goes through the mucosa, through the serosa, into the muscularis, and oops, now it's out. And now we have all of that gastric ick and all of that acidity in the peritoneum, which is a sterile area. So when we have that perforation and all of that stuff coming out into the peritoneal cavity, our patients are going to complain of abdominal pain. Their abdomen is going to be board-like and rigid, and eventually they'll develop septic shock because of it. Another problem that we can see is an obstruction of the distal stomach, or a gastric outlet obstruction. And this is a result of that, again, that peptic ulcer. It has edema and a little bit of inflammation, and they develop scar tissues. So patients that have a gastric outlet obstruction, first of all, they're going to complain of some abdominal pain. It's going to be worse at the end of the day because nothing is going through by the duodenum, going through into the small bowel. So as they eat during the day, the duodenum and the stomach are going to actually be distended. Relief can be obtained by belching or vomiting. Vomiting is going to be projectile. The vomitus is going to contain food particles. And we're also going to see some constipation with this, and that's because of dehydration. And if you have any questions, come see me in class. Thank you and have a great day.